Good morning. I'm Dr. Venugopal, heading the Department of Emergency Medicine at the MIMS. Now, this lecture deals with airway management in ER setting, its tricks and secrets. Objectives of this lecture include to emphasize the importance of airway management, to emphasize the management of a non-maintainable airway, to go to the principle and practice of rapid sequence intubation, and to define a difficult airway and to emphasize its assessment and management, and finally, once you intubate it, how to do the tube positioning and what are the problems in tube positioning. So the critical step in any airway management, emergency airway management include, or not only in an airway management, in any emergency cases, the focus is always on airway, breathing, circulation, that is ABC, and parallelly the management of the critical situation, which include IV access, oxygen, and monitor. So the critical steps in any emergency management include IV, oxygen, monitor, and airway, breathing, and circulation. Always follow a principle: assess, identify the problem, if a problem, manage it, and don't wait for further. What is an obstructed airway? Any patient presented to you with a noisy breathing is an indication of an obstructed airway. The common cause of an obstructed airway are the fallen back tongue and epiglottis. But you should also look at any visible foreign body in the oral cavity. If it is there, it should be first. This is a picture shows an obstructed airway where the tongue falls back and obstructing the airway from the airway obstruction. Here you see that a simple airway obstruction that clear, simple head tilt and inlet that clear the airway. The alternative technique of head tilt and inlet to open an airway is jaw thrust. This is mainly, the jaw thrust is mainly reserved for a patient with a trauma where head tilt is contraindicated. While managing an airway, the first question after your initial assessment, the next question is to be answered whether your airway is maintainable or not with the simple technique like head tilt and inlet. If it is not maintainable with a simple technique like head tilt and inlet or a jaw thrust, naturally this is the time to use airway. What are the airway adjuvants are available? Before using any airway adjunct, another question is to be answered is like, is there any airway reflexes are there or not? If there is no airway reflexes, the choice of airway adjunct is OPA or oropharyngeal. These are the few pictures shows that different sizes of oropharyngeal air. So before using an oropharyngeal airway, you should use appropriate size. The sizing of airway you should measure from angle of the mouth to the angle of mandible. This is a picture shows how to insert an oropharyngeal airway. This is a picture shows that how an oropharyngeal airway maintain airway by keeping away the tongue from the airway. This is a video shows how to insert oropharyngeal airway.
Hello. Hi.
The next question is like, if the patient is not tolerating oropharyngeal airway, or if the airway reflex are retained, or the patient is present to you with issue of inability to open the mouth. Obviously, a oropharyngeal airway is out of question. So the next choice is NPA or nasopharyngeal. Same as oropharyngeal airway, nasopharyngeal airways are also coming in different sizes. Here also you can size the, you should use an appropriate size. The sizing can be done from measuring from the nose to the trachea, and you can use either right nose or left nose depending upon the pattern. And oropharyngeal, nasopharyngeal airway should not be used in patients with fracture nasal, fracture basal skull, and other facial-maxillary injuries. Still, airway is not maintainable. This is the time to use advanced. The advanced airway includes absolute way of controlling airway includes placing an endotracheal tube into the trachea, and other advanced airway are for an alternative airway include LMA, combi tube. After managing the airway, if patient is not breathing, this is the time to give. We should give adequate rescue breath. And the ideal way of giving a rescue breath in an ER setting, in an emergency room setting, is using an ambu bag and mask. Here, the one point you should know, like you should know how to hold the mask appropriately. That is very important. Usually, you can use an EC clamp technique. The E is to hold the mandible, and the C is to hold the mask. And while maintaining or while giving breath, you should give cricoid pressure, which is an essential maneuver to prevent aspiration. In a non-maintainable airway, if patient is conscious or patient is semi-conscious with the retained reflexes, it is unreasonable to insert an endotracheal tube into a patient, where you have to think about a technique called RSI. RSI is the rapid sequence intubation, or it is otherwise called a intubation. RSI means virtually simultaneous administration of a potent sedative agent and a neuromuscular blocking agent to induce unconsciousness and motor paralysis for tracheal. What are the problems inherent to intubation? Why you want to use RSI? Because the laryngoscopy and intubation by itself a potent stimuli for the oropharynx and endorespiratory tract. This intubation causes on impact on respiratory tract, like it will induce bronchospasm, it increases intracranial pressure, which will commence release of catheter. So, who will be benefited from RSI? Obviously, those patients with tight head, tight heart, tight vessel, and tight lung. That means tight head means patients with intracranial pathology. Tight heart means the cardiovascular diseases, and the tight lung means reactive airway. So the 7 steps of the RSI can be remembered by just remembering 7 P's. This includes pre-oxygenation, preparation, pre-treatment, paralysis and induction, protection, placement of tube, and post-injury management. Actually, this is start with a timeline. The timeline starts from -10. -10 you start prepare, -5 you start pre-oxygenate, -3 you start pre-treatment, and at T0 timeline 0 where the paralysis and induction will start. From there, the 30 second plus 30 second, you give the protection, that is Calicut pressure. In the 45th second, you should place the endotracheal tube, and in the 90th second, you should go for the post intubation management. So, how will you evaluate airway? Airway evaluation is a mandatory step before any intubation, before any RSI. So, look at, is there any airway problem? Is the look at the epiglottis, look at the vocal cord. So there are many mnemonics to remember the difficult airway. One mnemonic is really remember the 4 Ds. 4 Ds include distortion, disproportion, dysmobility, dentition. Another mnemonic, just remember bones. Bones like bear, B for bead, O for obey, no for key, N for notice, L for elderly, N for nose or sleep or something. Another mnemonic is short. Short is S for surgery or sedena, H for hematoma, O for obese, R for radiation, T for tumor. And like there are many mnemonics, but very unreasonable to remember all the mnemonics. But an ideal one, just remember lemon method. I will give the details of lemon method and Malabati. But whenever you anticipate a difficult airway, you should always have the difficult respiratory. Malabati score is four classes are there in Malabati class 1 to 4. Class 1 is the easiest one, and class 4 is the most difficult one, and the other 2 and 3 is intermediate. In class 1, you can see the all oral cavity include the ovale, all the fossils, fillers, etc. In class 4, you can't see anything in the oral cavity. And the Malabati assessment, it is difficult to do, or it is not possible to do an unconscious patient. This is only for a conscious patient. Uh, you can expect worst intubation in class 4 and the easy one in class. The Lemon method of assessment is a 60-second examination of the airway. This L for look externally for any difficulty. E means evaluate the difficulty by using 3-3-2 rule. The 3-3-2 rule means using introduce 3 fingers into the mouth. If it is less than 3 fingers, that means in an open mouth, this means it's a difficult airway. Place 3 fingers from mentum to hyoid cartilage. If it is again less than 3 means it is a anterior larynx. If it again place 2 fingers to fit from mandible to the top of thyroid cartilage. And any of these is less than 3, less than 3, and less than 2 means the intubation will be likely to be a difficult one. In the lemon, L is look externally for difficulty, E for evaluating 3-3-2 rule, M is Malabati plus 1 and 2 is easy, plus 3 and 4 likely to be difficult, and O for obstruction, any obstruction in the airway, and N for to look at the neck. Whenever you are managing a difficult airway, you should always prepared with a rescue airway equipment, which include gum elastic bougie. This is a very useful aid for the difficult intubation. You should also get the rescue airway include a laryngeal mask airway. Whenever you are failed to intubate, sometimes this laryngeal mask airway will help you by time to provide oxygen. This is the picture of a LMA. This is a combi tube. All these LMA and the combi tube are the devices which can be used in patient without without any use of laryngoscope. Definitely, if another one is a surgical cricothyroidectomy, that this a picture shows the surgical. This is the endotracheal tube. Endotracheal intubation is the best choice for controlling the airway. Endotracheal tubes can be a cuff to prepare for an intubation. You need equipment. For intubation equipment include, you need a laryngoscope with a different types of blades. You should have different type of endotracheal tube, different types and different sizes. For an average adult male, an 8.5 is okay. An adult female, 7.5 is an appropriate. And always try to keep one size above and below whenever you are approaching for an intubation. Usually we use low pressure tube for above 8 years. And an uncuffed tube, if you are using, I'm sorry, not uncuffed tube, if whenever you are using pediatric cases, there are formulae to assess the tube. This laryngoscope with blade. So whenever intubation, our idea is, or the critical steps in an intubation is to align the three axes existing in the airway, and along with that, to prevent, we should use Select manual. The axes are, there are three axes to align in any intubation for a better visualization of vocal cords. The axes are oral axis, pharyngeal axis, and laryngeal axis. Practically in a supine position, all the three axes are in three different directions. So while doing simple maneuver like placing a pillow under the head, it will bring the oral and laryngeal, sorry, the pharyngeal and laryngeal axis in a same line, and just giving a head tilt, the oral axis also aligned to the same. So the a head tilt and a pillow under the head will bring oral axis, pharyngeal axis, laryngeal axis into a same line, or they get aligned. So the laryngeal scope. Next one is, whenever you are failing to intubate, we have the alternative like the laryngeal mask airway. Laryngeal mask airway is nothing but it is a silicone rubber device that that combines tracheal intubation and use of face mask. The use for It is used for the situation when intubation attempts have failed, bag mask ventilation is unsuccessful, and the patient need immediate. This is the one figure shows when this is LMA is also available. These are the different LMA sizes which can be used depending upon the size, depending upon the weight of the patient, starting from neonate to adult. Combi tube is practically, it is a combination of two tubes, and this is a very useful adjuvant in where the
All
airway is
components of the
complicated.
combi tube are set ready for use within the package. The combi tube consists of a double lumen tube that has two cuffs, one proximal and one distal. The larger proximal cuff is inflated via the blue pilot tube that is labelled number 1. The large syringe is preset to 85 ml and is labelled blue as well. This syringe is used to inflate the larger cuff. The pilot balloon to the distal cuff is labelled number 2. It is inflated with the smaller syringe, which is preset within the package. In most cases of insertion, the distal cuff will lie within the esophagus. Ventilation down the more prominent blue lumen will emerge out of the lateral side holes and go into the trachea. Rarely the distal tip will lie within the trachea. If oxygen is passed down the shorter white tube, it will emerge at the distal tip, rather like a conventional ET tube. Hence, ventilation of the lungs is possible whether the distal tip lies within the esophagus or within the trachea.
How the combi tube is placed. While inserting the combi tube, you can insert blindly. The tube may go either trachea or esophagus. That does not make any difference. 99% of the time, the tube will go to the esophagus. You inflate both cuffs start ventilating through the tube one, and if the chest is moving, that means the tube is in the esophagus, but still you will get an. This is the technique
With the head in the
of
neutral
looking for
position,
the
insert the combi tube blindly or with the use of the laryngoscope until the black marks come to rest opposite the incisor teeth. First, inflate the large proximal cuff that is labelled number 1 and blue. The combi tube may ride up like a laryngeal mask during this. Then, inflate the smaller distal cuff using the preset syringe.
So, what is the biggest disaster in airway management? Somebody can't intubate, somebody can't ventilate. The biggest disaster. So, how can you overcome? Where the situation you can use the rescue airway, where you can use combi tube, LMA, bougie assisted intubation if it is for a surgical airway. Transtracheal catheter is an catheter insertion, an emergency procedure performed when other airway methods fail. Though the needle catheter inserted through the cricothyroid membrane, initially we should insert a catheter, needle catheter inserted through the cricothyroid membrane, then give intermittent jet ventilation delivered through the catheter. The puncture of the cricothyroid membrane at 45-degree downward angle and cannulated. This is the transect. This final how the transect there, the trachea. This is the video show how to. Out the needle production. The other methods are also useful to control airway. This includes fiber optic intubation, which can be used as in a semi-electric scenario. This is a video as a cellular intubation is also easy. And after intubation, the important step, confirm. There are different methods to confirm two positions, which include primary methods and secondary methods. The primary methods include visualizing the pose, seeing the chest rise, semblance, and many others. But whenever you are looking at the uh, the two positions, first you should rule out the wrong position. So the in 5-point auscultation, the first point you should auscultate is the epigastrium. Then you go for the other right axilla, left axilla, right anterior, left anterior. But the absolute way of confirming position of the endotracheal tube is nothing but carbon dioxide detector. There are different kind of carbon dioxide detection methods are there, colorimetry method, then digital method and waveform method. Among the three, the most accurate one is the and esophageal detector device is a simple device helps to rule out an esophageal intubation. It can be a bulb or a syringe. It can be attached to the endotracheal tube and you can withdraw. While if you have a resistance to withdraw the syringe or the inflated, deflated bulb is not inflating to original position, then means tube is in the esophagus. So here it is the concluding discussion. Thank you for your patience.